Good evening, everyone, and welcome to today's webcast, Supporting Loved Ones with Psoriatic Disease. My name is Bev Bromfield, and I will be your moderator for tonight's presentation. Before we start, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined the presentation using your computer's speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit questions to today's presenters by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address as many as possible at the end. Additionally, during the presentation, we will have questions for you to respond to through our audience polls, which will be featured on your screen. Before I provide information about the foundation, I would like to thank our sponsor, Celgene, for helping to make tonight's presentation possible. Their support on behalf of the Care Partner Initiative is sincerely appreciated. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a new strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified: accelerate discovery to cure psoriatic disease, improve health outcomes, achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis. To learn how best to support your partner in managing his or her disease and to have a better understanding of what it means to live with psoriatic disease. If you have the disease, you can help accelerate efforts towards a cure and greater understanding of psoriatic disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of safety treatments, better understand conditions related to psoriasis, and explore the history of the disease. Your partner can share his or her experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientist. Answer questions and view your data along with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you and your loved one find physicians, treatment information, navigating insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation center. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in local Team NPF events near you. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar. To learn more about the physical and emotional needs associated with living with psoriasis and/or psoriatic arthritis, as well as related health conditions that impact overall health and well-being. As a care partner, you'll receive tips on how to support your loved one in making treatment decisions and how to cope with living with the disease. At the end of the webinar, resources will be presented to help you as a care partner. Now I'd like to introduce you to our first speaker, Lakshmi Aldridge. Ms. Aldridge is a nurse educator and board-certified adult nurse practitioner with the VA Portland Health System and dermatology services in Portland, Oregon, where she has been in practice for the past 27 years, managing a busy psoriasis clinic. Additionally, Lakshmi is a clinical preceptor training course facilitator at the VA, past president of the Dermatology Nurses Association, past chair of the Nurse Practitioner Society, and a member of the Emeritus Medical Advisory Board for the National Psoriasis Foundation. It is my pleasure to welcome Lakshmi Aldridge, who will present an overview of psoriatic disease.
Thank you so much, Bev, and it is my absolute pleasure to participate on this program with you, and I'm delighted to be here. Just some disclosures. I want to let you all know that I do have the following financial relationships as a consultant, speaker, and advisor for many companies that develop psoriasis medications. And truly my mission with partnering with these groups is to ensure that the voice of the patient is not forgotten, and that everything we do has at the bottom line patients and their loved ones. So there is a quick poll that we want you to do to understand a little bit about who our audience is. So what is your relationship to the person with psoriasis and or psoriatic arthritis? Please select one. Are you a spouse, a parent, an other family member, a friend or other caregiver, or you're the person with psoriasis or psoriatic disease? And I think we're getting some results in, and it's kind of a fairly mixed group, but quite a few of you are the folks that actually have psoriasis and psoriatic arthritis. And so we will be addressing a lot of information for both you as a patient and you as a caregiver or a loved one. A second question, how familiar are you with psoriatic disease? And if you would please select one. Very knowledgeable, somewhat knowledgeable, limited knowledge, or no knowledge at all. And I think we're getting those results in. So we have a nice mix also. Some of you are very knowledgeable, somewhat have some knowledge, and thankfully there's very few of you who have no knowledge at all. But regardless of your level of understanding of our disease, I hope to be able to present data that will be useful to all of you, regardless of your level of understanding of the disease. Okay, so moving forward, let's talk a little bit about a care partner's role, and that is really to support your loved one as they manage day-to-day life with chronic, lifelong disease such as psoriasis or psoriatic arthritis. So what is psoriatic disease anyway? Let's get down to the bottom line. What are we talking about? So this I find very interesting. This is a historical perspective, and psoriasis has literally been around since the biblical ages. So Hippocrates, which some folks call the father of medicine, described these dry, scaly eruptions under the heading of lupoi, which is why psoriasis was mistaken as being leprosy for a long time. And in fact, both psoriasis and leprosy were grouped together in the Old Testament. And in fact, patients with psoriasis were treated as lepers, and they were isolated from their communities. They were declared dead. They often lived outside of the wall of the city, and they would have to ring a bell before they would come into the wall, through the wall to, for example, shop for goods, and people would scatter because they were afraid that this was a contagious disease such as leprosy. And so to this day, a lot of folks still have a lot of misconceptions about psoriasis. So we can see that it has a long history back in the day. Having a little trouble advancing the slides here, so I'm going to ask Bev to assist me with that. So you can see some of these pictures here. These are patients with psoriasis, and you can see on the right-hand side the arms and hands of a patient with psoriasis. And on the far left side is a young woman with psoriasis extending on her back and her arms. And you can see how extensive this is and how bothersome and emotionally taxing having this disease can take such a toll on people's lives. And now we understand so much more about the disease. So it really wasn't until 1841 that psoriasis was differentiated from leprosy. And there was a physician by the name of Heinrich Kebner who noticed that psoriasis would occur oftentimes on places in the skin that was injured. For example, where someone fell or scratched themselves, as in the picture that you see, or if they, for example, had surgery. So oftentimes the first site of psoriasis will be over the surgery scars, such as a knee replacement. And so trauma or injury can be the cause of initiating psoriasis. And so the Kebner phenomenon is known as the artificial production of psoriatic lesions. And it was a way that was used to differentiate psoriasis from other skin conditions such as syphilis. So our understanding has truly come a long way. But this is typically what psoriasis looks like. So it is very well demarcated, which means that you can clearly draw a line around the plaques. And when I say plaque, what that just means is it looks like someone took some glue and mixed it up with water and stuck it on your skin. That's a plaque. It's raised. You can feel it. Typically, it occurs on the scalp and the elbows and the knees, the fingernails, the hands, the feet, but it can really affect any place, including the face, the genital area. So really, there's no place that's not affected. It's interesting that our understanding of nail psoriasis, a lot of times we miss that, but the manifestation of psoriasis in the fingernails and the toenails often gets confused with fungus. So that's something that we are also starting to pay attention to. So how do we grade how severe a patient has their psoriasis? So what we use is something called the BSA, which stands for body surface area. And basically it's the size of a palm. So one palm is 1%. So mild psoriasis is 3% BSA, or 3 palm size, and moderate is 3 to 10%, and severe is more than 10% body surface area, or more than 10 hand or palm size plaques scattered all over the body. Now, that's not to say, though, that in places that are very sensitive, for example, the palms of the hands, the soles of the feet, or in the genital areas, it can be incredibly bothersome to have psoriasis in those areas. And so that can be considered severe disease, even though it may be less than 10 palm size or 10% BSA. So the question is taking a good look at the patient, evaluating how much of their skin is affected, and then asking about how it impacts their quality of life. We take all of that into consideration, and then we determine the severity of the disease. So it is not a set number, and severity can wax and wane over time. So how do we assess psoriasis? Of course, we do a comprehensive physical exam to determine if you have mild, moderate, or severe disease. We want to take a very thorough history of medications, because we do know that there are some medications that can cause psoriasis, such as blood pressure medication or some antidepressants. So it's really important that you write down a list of all of your medications and share that with your providers. And then also getting a good, thorough medical history. We're looking for comorbidities. And what we know about psoriasis now, our knowledge and understanding from even 5 years ago has expanded significantly. So we know that psoriasis can lead to other conditions, which are called comorbidities. That can include psoriatic arthritis, diabetes, hyperlipidemia, which is high cholesterol, obesity, cardiovascular or heart disease, malignancies or cancers, and depression and anxiety. And psoriasis can look like a lot of other different skin diseases. And that's why we call that differential diagnoses. So oftentimes psoriasis can be mistaken for eczema or an allergic contact dermatitis or another condition called seborrheic dermatitis, drug reactions, tinea or fungal infections, and other conditions called pityriasis rosea or lichen planus, which are also itchy red bumps. Candida and onychomycosis are also yeast and fungal infections. So it really is important to do a good, thorough physical examination, get a good medical history, and then really be able to know what psoriasis looks like. And if we don't know, then we may need to take a skin sample or a biopsy to help us clarify the diagnosis. So these are some of the comorbidities or associated health conditions that we now know are attached to psoriasis. The most important is cardiovascular disease, which is related to the heart. So we know that patients with psoriasis, if they have severe disease, they can be at increased risk for a heart attack or a stroke. Metabolic syndrome is a collection of different things, including high blood pressure, high cholesterol, high blood sugars, and that can lead to heart disease. Obesity is associated with psoriasis. Dyslipidemia, which again is high cholesterol. Psoriatic arthritis, which is inflammation in the joints. Mood disorders such as depression and anxiety. We used to believe that, of course, patients with psoriasis are going to feel depressed and anxious because they have a very visible disease. They wear their diseases on the outside of their skin, whereas patients with, say, diabetes or high blood pressure, nobody knows if you have those conditions unless you happen to share that with them. But patients with psoriasis have the unfortunate downside of wearing their disease outside of their skin, which can be very difficult to hide. We also know that inflammatory bowel disease, such as Crohn's disease, can be associated with psoriatic disease. Certain cancers, uveitis, which is inflammation in the eye, and alcohol and addictive behaviors have also been associated as a risk associated with psoriasis. So these are things that we are educating patients about and screening for patients who have skin symptoms. Psoriatic arthritis is a really, really important comorbidity. And I'll tell you why. Because the skin cells, we can always reproduce and make new skin cells. But once you start getting inflammation in the joints and the tendons and the ligaments, then you start having deformity of the joints and pain and disability. And once those joints get destroyed, you can't get them back. So our goal is to identify early symptoms of psoriatic arthritis and get patients on a medication or a treatment regimen that is going to halt or stop the progression of that inflammation so that we can maintain the bones and the tendons and the ligaments and prevent further destruction. So some risk factors for developing psoriatic arthritis: the more severe the skin disease is, the higher the risk of developing psoriatic arthritis. If you have nail symptoms such as pitting or oil spots or thickened nails, that can be a risk factor. And also uveitis, that inflammation of the eyes. But in general, we know that patients with about 30% of patients with skin symptoms will go on to develop joint symptoms. So the goal is to diagnose this early and get them on treatment so we can prevent them from developing disability. So this is, again, a great picture of a patient with psoriatic arthritis. You can see those swollen ankles, the kind of deformed toes, the nails you can see are dystrophic or absent or deformed. That's a key signal for psoriatic arthritis. Most of the time, the skin plaques will precede or come before the joint symptoms, but not always. And psoriatic arthritis, it can have a waxing and waning cycle. So sometimes it gets better, sometimes it flares, it'll become quiet, and then all of a sudden it will become really painful. So again, We can have progressive joint damage, which can result in increased mortality or the inability to function. And it can also result in an increased risk for heart disease. And again, that risk of heart attack or stroke, which of course is also extremely serious. How we diagnose psoriatic arthritis. So really, this is a complex process and is best done by rheumatologists who are our partners. In dermatology and rheumatology, providers work very closely together to take care of our psoriasis patients. So we look for joint symptoms, we look for tendon symptoms. Dactylitis is the development of those swollen toes and fingers called dactylitis. It's called sausage finger or toe. Low back pain, and who among us does not have low back pain? But in patients with psoriasis, we need to pay attention to this because this can be actual inflammation in the lower back that can be a signal of psoriatic arthritis. And then peripheral arthritis, which is simply inflammation of the distal fingers and toes. That can be some of the first areas. So it just feels like it could be one thumb, it could be the distal, the tips of your fingers, the first joints there. Again, those nail symptoms. And then enthesitis. Enthesitis is inflammation of the tendons where they connect to the bone. And oftentimes a classic area is the Achilles tendon or your heel. And sometimes when you feel that, it will be very, very painful. And a lot of people think, oh, it's just plantar fasciitis. But this is actually psoriatic arthritis. So it's not just the bones, it can also be the tendons and the ligaments. Again, we talked about that inflammation of the eye. It's usually one eye, can come on very suddenly, but that's a key symptom of psoriatic arthritis. And then, of course, if you have plaque psoriasis or the skin symptoms, that also increases your risk of having psoriatic arthritis. So that's a really big comorbidity that we're paying more attention to. Next slide. So let's go on to poll question number 3. On a level of 1 to 4, how stressed do you feel in relationship to the management of the disease needs of your partner? How do you feel in regard to that? Not stressed, somewhat stressed, stressed, extremely stressed, or it's not applicable to you? I'm anxious to see how folks are voting on this because it can be very difficult to be the partner of someone who suffers from psoriatic disease, absolutely. And we also have a nice mix of that as well. So some of you feel very stressed, some of you don't feel stress at all, some are somewhat stressed. So we will talk a little bit about why it's important to make sure that people are getting managed properly and that you as a caregiver and as a loved one also have support and resources to help support your loved one with psoriatic disease. Okay, so this is another really important slide, and this shows, this is a survey that was done, and it shows the difference between patients and providers with regard to how severe their disease is. So the blue box, the blue bar is patient's perspective, and the red bar are how dermatology providers felt. So you can see the difference between itching. Patients really thought that itching impacted their quality of life and their severity, much less so than providers and than their dermatologists. Whereas dermatologists really thought that the most important factors that contributed to the severity of the disease is how many plaques they had on their body, which is really interesting because patients didn't feel like that was that important. The itching really played a much higher role in how severe their disease is. Scaling also played a part in patients' eyes versus dermatologists felt that that was not as important. Flaking of the skin, and then, of course, joint pain and swelling, that was a huge factor for patients as well. So the point being is is that there is a difference between what patients perceive as contributing to their severe disease versus what their dermatology providers perceive as being important in grading their disease. So it's really important that patients, loved ones, and their providers communicate and get on the same page, because at the end of the day, it really is about the patient. So this is another study that was done with psoriatic arthritis, and this was with about 1,000 patients, about 100 dermatologists and 100 rheumatologists. And the findings reported that both skin psoriasis and psoriatic arthritis continue to remain undertreated in patients who have even moderate and severe disease, and that there were gaps in care, including screening and assessing patients and treating and diagnosing patients with both skin psoriasis and psoriatic arthritis. So we definitely have a lot of work to do to ensure that patients are appropriately screened and diagnosed and then appropriately treated. There was also widespread dissatisfaction with current treatment options. So many patients with psoriasis and psoriatic arthritis are not on the appropriate treatment. So there is lack of efficacy. Patients aren't getting clear. Patients' pain isn't being controlled. We don't explain the safety risks of these treatments. There can be administration challenges. So some patients don't want to give themselves injections or take pills or apply topicals or come in for phototherapy. And then goodness knows the cost of treatments can certainly be prohibitive. So those all play a factor in patients and family members' dissatisfaction with their current treatment. And again, there's that continued difference in perception of severity. And this plays a huge role, because if you don't feel like, as a patient, that your disease is very severe, but we as providers do, or vice versa, you feel your disease is severe, but we don't, and we don't offer you the best treatment, then you're not going to get the best treatment possible. You're not going to be happy with your treatments. So I put this slide in here, which is very, very complex, but I just wanted to go through it very quickly because it's a nice historical perspective of the different treatments that we have for psoriasis. So again, when we first thought that psoriasis was just a skin disease, we put ointments and creams on it, and there are lots of those. So there's topical steroids and vitamin D analogs and cold tar treatment, and all of these are recommended for mild disease. But it's really difficult to get patients to continue to apply these over and over every day on their skin, and it's also really messy sometimes. Phototherapy, which is not the same as a tanning booth. Let me make that very clear. Tanning booths have high risks of melanoma and skin cancer, whereas phototherapy, which is regulated narrow band ultraviolet light, is recommended for moderate to severe disease. There's a slightly increased risk of developing skin cancer, and it can work very, very well for your skin, but it will not address psoriatic arthritis. And it can also be inconvenient because you have to come in 2 or 3 times a week. Methotrexate, cyclosporin, and acitretin are all pills that are recommended for moderate to severe disease. And in cyclosporin's case, we use it for flares. And they all work very well, but they can be very slow to work, and they can have some significant side effects. Acitretin and methotrexate we absolutely do not want to use in folks who are thinking about becoming pregnant, both men and women. And there can be toxicity with some organs. So we monitor that very closely. And then finally, we've had biologic agents, and those are the injections that have come along in the last 20 years that have really changed the way that we treat psoriasis and psoriatic arthritis. And they are indicated for moderate to severe psoriatic disease, and they can be used as first-line treatment. They're very, very effective. The downside is they're also very, very expensive, as many of you, I'm sure, already are aware. And going forward, and I'll have another slide. This slide here is much, much more extensive. And the reason why I have this out here is because you can see that there have been so many new medications that have come around in the last 5 years even, and there continue to be new and more amazing medications. So the real message is that we have lots of options, and if you've tried several things or your loved ones tried several things and they just don't feel like it's working and they're hopeless, there's lots of other treatment options available. So there is so many treatment options, and so there's really, it's a good time to have psoriasis because we have so many ways we can treat you. So what are the things that we take into consideration in thinking about putting you on the right treatment? Well, we look at age. We look at your family planning if you're thinking about starting a family or if you're recently pregnant and breastfeeding. We want to take a good, thorough history and find out if you have a history of cancers, multiple sclerosis or other neurological disorders or heart failure, inflammatory bowel disease such as Crohn's disease, depression or suicide, chronic infections, other autoimmune conditions, history of infections such as fungus or TB, hepatitis B or C or HIV, and alcohol consumption and smoking. Those all play a part in determining what kind of treatment we're going to give you. And then we also want to monitor you closely. And the National Psoriasis Foundation collected a group of psoriasis experts, and they came out with a statement about what is the end goal. And what we are thinking is acceptable is we want you to have less than 3% of the palm size areas of your skin involved after the first 3 months of treatment. But the goal is for you to be clear or near clear or have a body surface area of less than 1% at 3 months after treatment. That's really the goal, to get you clear or near clear. And we want to monitor you closely every 3 to 6 months, and we want to reassess your skin symptoms or your joint symptoms if they're not under control. And we really rely on you as our patients to tell us when something's not working. So here are some take-home points. It's really important to find a dermatology provider that has a specific interest in caring for psoriasis patients. This is my passion. I love, love, love my psoriasis patients, especially those in the veteran community, because obviously that's where my home is, at the VA, and they're just precious to me. So find a provider who loves taking care of psoriasis patients. And you can go on the National Psoriasis Foundation website for providers who have indicated that they have an interest in that. Go with your loved one, or if you have psoriasis yourself, take your loved one with you to your appointment. It's always nice to have a second set of ears. Sometimes you can be overwhelmed. It can be scary. So just having another set of ears can be helpful. And then come prepared. Write down your medical history. Write down your story with psoriasis. That's the first question I ask my patients. Tell me about your psoriasis story. Where did it start? How did it start? How is it affecting you? How is it affecting your loved ones? I want to know about your journey with this disease. What does it keep you from doing? Write down a list of your medications, and even better, bring your medications with you. And then write down what you have tried already for psoriasis, or what has been prescribed for you for either your skin and your joints, and then how did it work for you? A lot of patients come in and tell me, I've tried everything and none of it worked. I said, okay, tell me what you've tried. Well, I don't know. I've just been trying everything. That doesn't help me. You have to bring in your medications, or at least write down what has been tried, so we're not reinventing the wheel and putting you through the ringer again and starting from scratch. Okay? And then also write down the questions ahead of time. List the symptoms that you're having. You're having severe itching. You're having pain and burning. You can't sleep at night because it's so awful. And then I want you to ask your provider about comorbidities. We talked about that. If your heart disease is getting worse or your joint symptoms are getting worse, those are things you need to bring up and talk to your doctor about, and ask, is that related to my psoriasis? It is terribly important that you have a good primary care provider, or your loved one has a care provider who can help assess with the comorbidities. So I can do a great job of managing your skin symptoms, and I can do a great job of saying, yes, I think your heart diseases might be related to this, but I can't manage your heart disease. That's why it's important that you have a good primary care provider. And be honest with your provider. I always say, I'm in this for the long haul with you. I'm going to be your partner in this. So I want you to be honest with me. We're going to have a good relationship. I want you to trust me because I want you to be able to tell me how your psoriasis is affecting your family, your job, your quality of life, which includes how you sleep, your sex life, your relationships with your family members. If you're not able to take your wife out for dinner on your anniversary because you're embarrassed of how your skin looks, that's significant. If you can't take your daughter to the father-daughter dinner dance because you're worried about embarrassing her, that's significant. I want you to tell me what brings you joy in your life, and I want to do everything that I can to get your psoriasis under control so you can live the best life that you can. I don't want you to have to give up on anything because of your psoriasis, okay? So that's really the goal, and the only way that I can know that is by you being honest with me, okay? So your loved one should expect that his or her provider manages their skin disease so that it is clear or near clear. That's good. Just having your provider say, that's good enough, that doesn't cut it. The goal is clear or near clear. And you and your loved one should be the driver of your health care. It's not up to me to tell you what's good enough or how you should feel or what you should do. It's up to me to give you as many resources and tools to help you live the best life, okay? So with that, I hope that has been helpful, and I'm going to turn it over to our wonderful care partner advocate, Scott Greenwood. Scott?
Thank you very much, Lakshya. I appreciate all that information, and wanted to start by thanking everyone for being out here and listening today. I think it is incredible that each of you is trying to gain knowledge and grow and find a way to actually bring some joy back into your life, or expanding the amount of happiness and joy that you have. So wanted to let you know that I'm not a professional speaker, and so I'm a caregiver and a partner to a wonderful wife who has lived with psoriatic disease from quite some time. So she's actually had it since 1991, which is quite some time, but she and I have actually only been dating since the summer of 2014. And at the time we had a 12-year-old daughter. You can see some photos there. And her primary caregiver was her daughter up until that time. And now I like to think that we kind of handle things together. But one of the big things that I'm here to kind of tell you about is how to improve on what you have going on, because we can all improve on things, improve on our own life. So this is just one component of your life, and there's a way that you can look at it so it's not overwhelming, and a way that you can figure out how to make it better. And that's what my wife and myself and my daughter have done. And I'm trying to change the slide here. Bev, maybe you can help me with the slide. And by the way, that was us on vacation and doing all types of stuff. So we're going to take a minute to do a quick survey here as well. If you could go ahead and answer the question. Great, and we've got a variety of answers coming in. Talking frequently seems to be on the top of the list, and I think that's fantastic. Something my wife and I do quite often. Open communication is a huge key to what's going on. It's not always possible. It's not possible because the caregiver maybe had a tough day, and the person with the psoriatic disease, or the other way around, wants to talk, and it's just not going to happen. You've got to find a way to kind of move your way through that so that both parties can participate in that. Big thing is listening and looking and seeing what's happening. So in a lot of cases, I will ask my wife, how do you feel? And she'll say, I don't know, I just hurt all over. And it's in part important to be able to say, well, how did it feel compared to yesterday? Is there any isolated place? Is there anything like that? So communication is big on finding out what's going on and seeing what you can do to help. If someone's not providing you with information, maybe you can come up with some ideas and say, how about a cold press or a hot press, or let's try this or let's try that. And quite frankly, sometimes they want you to just leave them alone. Just leave me alone for an hour and let me see what's going on, and then let's come back and try it again. One of the big things I like to talk about and we work on is try not to get frustrated. It's hard sometimes, but people are not going to want to talk. They're not going to know how to communicate. They're not going to know what to say or how to convey it. This is a learning experience for all of you, and you're trying to figure out what you can do to help. The best way to do that is to pay close attention, ask questions, and be really in tune with their needs and what they need, in my opinion. So I also talk here about finding a group or someone who gets it, finding your support group. If your spouse is going to be all supportive, that's great, but I think you need to find other people as well. And the National Psoriatic Arthritis Foundation is a great way to make connections and a great way to find people that can support you in your day, in your journey, in your healing, in your recovery, and quite frankly, just having a lot of fun in life. You know, I have people that say hi to me every morning that walk my dog. I feel like they're part of, you know, the happiness of my life because I look forward to getting that. So it doesn't have to be someone that's providing you with a huge amount of information. So I think that's key as well. Being prepared and ready to help, I think, is also there. So it talks about having, you know, a pack in the freezer, a hot pack, you know, having towels ready, having food and comfortable situations so that you can accommodate to what's going on. And then I also think it's important to keep you healthy as well. So you want to have, as the caregiver, some activities. You want to eat right and exercise and make sure that you're strong for the individual that you're taking care of. And I think that's an important thing to look at as well. So Bev, if you could advance the slide. That's great. So I put here time changes everything or everyone. You know, psoriatic disease in a lot of cases changes your life. Well, I ran in the New York City Marathon in 1990. I don't have any aspirations of running another marathon, but I do fun things every week and a lot of fun things. My wife and I very much love going out and getting lunches and dinners and watching movies and all of these things. And one of the things I wrote down to make sure that I emphasize is you're not always going to feel great, but when you do, take advantage of it. Have some things planned or some things ready to go and get up, get out, do something when you feel good because you're not going to feel great all the time. So my wife and I have a restaurant we love to go to. We have a walk we love to go on. And when she's feeling good, we get up and go. And that's what you remember and think about. And it helps you with the healing process quite a bit. Next slide. So I think that life is not just about living. I think it's about having a wonderful experience. And regardless of what you have, regardless of your limitations or your expectations or what you think about, there's great, fun, interesting, exciting things that you can do out there. People love things to look forward to. So, you know, it reminds me of the movie City Slickers, and Curly said, you know, life is about the one thing. And that one thing, I think, is something to look forward to. You know, whether you're a human being without major illness or with illness, if you have something to look forward to, I think that just brightens your day. And what my wife and I talk about is a time together, not necessarily a specific event, and having some secondary plans so that if she's not able to do our primary plan, we move to secondary plan that's not as active, doesn't take as much energy, and is not going to cause pain. So one of my ideas is maybe have 3 movies that you love, set those aside and don't watch them. If you have an event planned and your partner can't go to it, say, boy, I'm really looking forward to watching this movie, and pull out the movie and dive right into it. And I wouldn't say, boy, I'm sorry we can't do this thing. Really, if you're looking forward to the movie, make that the exciting focal point and let them know that you're excited to watch the movie with them. That'll enhance your life and make it great. But I think you need to look at what your interests are, not only when you're in pain and are not able to be mobile, and when you're not and you're able to do things, and being able to look forward to that and kind of diving right in and going from there. So I kind of put in conclusion, sometimes we need to be reminded how lucky we are to be here. And life is what you make of it. And it really is. I think it's something where you can have an exciting life and move forward and find exciting things to do. When you're in pain, find something else to do, but have something to look forward to, something to build on, something to grow on. Keep up the communication. And I think that's how you'll create your own wonderful world, which, again, it's not the New York City running marathon world. It's a new world, but you can still have a lot of excitement and great things going on. So, Bev, I think that's it from my end.
Okay, thank you, Scott and Lakshi, for sharing your insights with us. We'll now move into the Q&A portion of our webcast. If you have any additional questions based on what you've just heard, please submit your questions for Ms. Aldridge or Scott through the panel on your attendee interface. We will attempt to answer as many questions as possible in the remaining time. Okay, so I will pose a question to Lakshi. So one of our attendees would like to know, how do you select or where do you find the right doctor who keeps informed about psoriatic arthritis?
So that's a great question. So psoriatic arthritis, there are a lot of dermatology providers who have now become trained in the management of psoriatic arthritis. But if psoriatic arthritis is your primary symptom, then I would strongly encourage you to get a referral to a rheumatologist. A rheumatologist is your expert in the joint and muscles and tendons. And again, there's a list of those providers through the National Psoriasis Foundation. But you can also just Google rheumatologists in your area, and then you can call their office and say, I would, do you manage psoriatic arthritis patients? So I think that's a reasonable way to approach it. But the National Psoriasis Foundation can be very helpful in helping you vet those providers who really take the time and knowledge to be involved. You can also Google rheumatologists and look up their names to see if they've published articles or published or spoken at meetings, if they're experts. But again, the National Psoriasis Foundation can help you with that information as well.
Okay, great, Lakshi. The next question is for Scott. Scott, one of our attendees is asking, how do I get my adult family members to realize that I'm not lazy or selfish when I don't feel like I can constantly do something for them?
Well, my wife usually just throws something at me, so I wouldn't recommend that. So it's, I think one big thing is education. If they're willing to read about it and understand what it is, they'll understand how exhausting the disease can be and how much pain you can be in. And in a lot of cases, you're creating your own new normal. So you may be in pain all the time, and you're just, able to cope with that. And then, some days you are not as strong and it catches up with you. So I think education is huge, reading about it. And I think trying to find a way to explain it to your spouse or caregiver in a way that they'll understand. I know I had broken my knee when I was younger, and my wife had explained to me, "You remember when you did that? It's very similar to that." So I'm not lazy. I'm going through that every day, and that helped me understand.
Okay, that's a perfect analogy. Thanks, Scott. Lakshmi, here's a question for you. Can two different biologic medications be used at the same time?
That's a great question, and very typically the answer is no. So if you have to be on two different medications, that means that one is not working. And now that we have so many different treatment options, we really don't want to increase the burden of medications on the immune system. So for example, I can think of a couple of different scenarios where that might be the case. So for example, if you're on a biologic treatment and your skin is super great clear, but your joints are not well controlled, and so you're seeing a dermatology provider, they have you on one biologic for the skin, you go to a rheumatologist and they want to put you on something different for your joints. Very typically what we'll do is so as a dermatology provider, I'll chat with the rheumatologist and say, hey, his skin is well controlled, but I see that his joints aren't. Why don't we consider switching him to such and such? And then they can concur. So you really don't want to be on two biologics at the same time. It's just adding extra burden to your immune system. And we have so many new treatments now that you shouldn't have to do that.
Okay, terrific. Scott, here's another question for you. How do you deal with frustration and burnout? Why do you get mad at the person who has the disease, and how do you handle it?
That's a good question. I think a couple things that we talked about in the presentation here is taking care of yourself. You need to have a little bit of time for yourself. You need to have a little bit of activity that you do. You need to make sure that you're getting exercise, you're eating right. If you're not strong, you're not going to be able to help as much as you can. I think activity is important. We talked a little bit about finding things to do together and really enjoying and sharing the time. But I hope that folks have a little bit of time to themselves. I think part of the things that made my parents' marriage so successful is that my dad would go and play golf and my mom would take off and do something. They'd get back together at the end of the day and talk about what they did and really enjoyed it. I wouldn't recommend going off for that long, but you want to have some interests on your own so that you feel like you're still your own person and that you're strong from that standpoint.
Okay, good advice. Lakshmi, here's another question for you. Should patients who have psoriatic disease be on a drug that treats skin and joints in the event that they might have joint implications later?
Absolutely, and that's what a lot of these biologics do. So we have kind of the added benefit. So when I see a patient who has psoriasis, I constantly screen and ask them about joint symptoms. But even if they don't have joint symptoms and they have moderate to severe psoriasis, I'm going to put them on a biologic agent because I want to prevent all of those comorbidities that we talked about, heart disease, diabetes, as well as the joint symptoms. So all of those, all of the biologics do have some preventive properties in progressing the disease. So if you think about the train leaving the station, we want to keep that train. That's not the best analogy, but think of a fire. Think of a fire roaring out of control. I want to contain that fire and keep it from progressing and getting worse. So I'm going to try and keep it contained as much as I can. And that's what we're doing with the biologic agents, or even with methotrexate or any of the, or Otezla is another one, another pill. It doesn't have to be a biologic agent, but whatever the agent is, we want to try and control their skin symptoms, because we know that the skin is a reflection of the inflammation that's happening internally. So I know that if their skin is clear, they're going to be less likely to have more aggressive disease that progresses and potentially causes psoriatic arthritis.
Okay, great answer. Scott, a question for you. How do people deal with the itchy skin and the tiredness from the perspective of a partner?
Well, the tiredness, I can kind of address both of those, but the tiredness is part of the disease itself, and it is it just kind of is what goes along with it. And I think if you know that and can anticipate that and can understand that it's not that they're cranky or that they don't want to talk or that they don't want to do something, that truly they're just exhausted, and also understand exhaustion can come on in 10 minutes. 1 minute they feel great, 10 minutes later they're saying, I'm not interested in going to this. If you understand it's nothing personal, that they're trying to get through this and they want to go to this themselves, I think you can adjust and adapt and figure out what you can do to try to help them in that standpoint. I think from the itchy standpoint, I think anything you can do to help them go get help. I think Lakshmi has talked about a lot of great stuff and where to go to try to help with that, and then to try to be understanding. And hopefully if you've, again, done the things that made yourself strong enough, you can be there to help them in that sense as well.
And Scott, that's a great answer. I just want to add to that. I can't tell you how important these questions are that you're asking, because you should not have your partners, your loved ones should not be feeling this way all the time, because then it tells me that they're not on the appropriate treatment. When we get patients on appropriate treatment, they come back in and they said, Lakshmi, I had no idea how tired and exhausted I was at the time, all the time. You don't even realize how exhausted you are until you're free of that. And the image that I have in my mind, which makes me have greater empathy and understanding for my patients with psoriatic arthritis, you need to picture that they are carrying a heavy load of bricks all the time. It's a heavy load of bricks that they can't put down. That picture should tell you then why they're always exhausted and why they're always tired, because they're carrying this load that they can't put down. Our goal with the right therapy is to remove brick by brick that load and free up those symptoms, free up their joints, free up that inflammation. And then subsequently, again, once they start getting rid of that load, they start to feel like their selves again. And they say, oh my gosh, I didn't realize how exhausted I was, how tired I was. I had the best night's sleep for the last week. That hasn't happened in years. So this is the goal, is the hope that these treatments can provide to get patients under control. And it may not always be with medications. It can happen with yoga, with physical therapy, with Reiki, Tai Chi, getting in the pool. The pool is a wonderful resource for patients with joint symptoms, because the water, you're able to exercise and lubricate your joints without that burden of stomping on the ground by walking. Just even walking can be incredibly painful. Again, picture that load of bricks. So I hope that that is a helpful image that will help you as caregivers have when you get frustrated or sad with your loved ones being tired all the time. Just imagine them with that load of bricks. And the hardest thing is that you're not able to remove that load for them and carry it, even though I know each and every one of you do everything you can every day to help support them, and you would if you could.
Lakshmi, that's a great way to kind of wrap up our discussion. You've kind of talked about the burden, and there are other resources that we have to help out. Thank you to both you and Scott for your answers. Other questions can be addressed to the Care Partner booklet that's available through our Patient Navigation Center. So I urge you to either call or send an email to the Patient Navigation Center to request a free copy. You can also call our Patient Navigation Center. If you have other questions, certainly we couldn't answer all questions tonight, but they're available to reach out, and you can answer many of the questions that most of you had, they can help you with. Also, if you feel that you need additional support, or if your loved one who has the disease needs support, our one-to-one program is there to speak with someone who understands what it means to live with the disease. They're trained, they have information about the disease and resources. However, they do not provide medical advice. So to request a one-to-one program volunteer, you can speak with a patient navigator who can help make that connection for you. If you're a parent and you're looking for additional resources, we have our spot that has age-appropriate information. And I'd like to thank, again, our sponsor for helping to make tonight's presentation possible. And finally, I'd just like to mention you can access our complete website archive by visiting psoriasis.org/webcasts. Future webcasts will feature hard-to-treat areas, such as the nose or the ear. Also, we'll have something on palmar-plantar psoriasis in 2019, so please watch for announcements of those webcasts. This concludes our webcast for tonight. Thank you for joining us, and have a lovely evening.